No.
Testing 1 2 testing. Hello everyone, welcome to the Prostate Cafe, our monthly meeting. I'm here to answer all questions as it relates to prostate and prostate cancer to the best of my knowledge. I would like to thank the Janssen company who sponsored our breakfast. They have some very interesting agents, many. We use them here, and they're very interesting. You know, we all know, or you probably do know, about hormones. And hormonal therapy generally implies that you're actually taking away the male hormone, testosterone. And that's what they do, and they come in all varieties, injectables and pills and what have you. And we do think those are very necessary because the data does support their use. However, there are other classifications or other groups of medications now which have become available, and of which Janssen has a couple of the products, one of which is it doesn't take the testosterone away. So the ones that do take it away actually shut down the production of testosterone from the brain. And it does a very good job of that. But the more recent agents that are typically used in combination with that one that shuts down the testosterone is a little more precise and smart in that it just doesn't allow the testosterone to touch the cancer receptor. And so that's very interesting. And they have a product that we use a lot here. It goes by the name of Relita. It's also known as apalutamide. And it's one of many now drugs like that we call androgen receptor inhibitors. They also have another agent, which is very interesting. You know, cancers, generally speaking, the reason why we have such a difficult time defeating them is because they become resistant. They want to repair whatever damage you do to them. You know, they just have this incredible ability to repair their DNA, even if it's struck down and it's spliced and it's, you know, beyond repair. Well, they go out of their ways to repair it. So there's another drug, or let me say, classification of drugs that we call PARP inhibitors, and they stop that repair mechanism. So, and that's one of the agents, again, that Janssen has. So they're really onto something. You know, our hope is that they continue along that avenue, because if they do, I mean, that's the answer to, you know, curing cancer. Just don't allow them, hit them with whatever you got, just don't allow them to repair, because that's the big deal with cancers by and large. So anyhow, I'm here to take questions from you if you have them. If you don't, I have a gift to talk. Yes, sir.
Yeah, how active is the immune system to keeping those cells from repairing?
So he's asking how well our immune system is in maintaining repair. It's extremely important. Okay, and we think that generally speaking, cancers arise because our immune systems failed us. And there's always cancers lurking, and there's theories that we all have cancer, but our immune systems are keeping the cancer in check. And it's only when our immune systems fail us that the cancer can start growing in an unbridled way. And so having said that, it appears important to always maintain our immune systems as best as we can. And we do have ways of doing that. You know, certainly healthy eating patterns all have to do with boosting our immune systems. And, you know, we talk about things like the Mediterranean diet, which is primarily fruits and vegetables and select meats like fish and poultry, and not red meat and pork. The blue ozone diets, where people live the longest centenarians in the world, and even 90-year-old plus is the most congregation of them live in those countries called blue zones. Interestingly, they all get a lot of sun too. And we do know that vitamin D3 really catapults our immune system. So D3 is instrumental in doing that. But those people in the Mediterranean and the blue zones, they also maintain a fairly active exercise routine. If not formally exercising, they walk a lot, and we think walking is one of the better exercises we all can do. You can lift weights and do resistance training and it's all good for you, but just walking, is a really healthy thing to do, and it does increase your immune system. There are other vitamins that we're aware of that also boost the immune system. They go by names of antioxidants, but vitamin C, we've all heard of that. Linus Pauling, vitamin C, it's been around for a long time. And we know that can boost the immune system. Zinc, very powerful in boosting the immune system. And there are others. Quercetin, you'll hear around here about turmeric, which is also known as curcumin. They're both kind of very similar. And polyphenols, which have to do with agents which interestingly have anti-cancer properties themselves. But resveratrol is a big one. And resveratrol is in red grapes. It is in red wine, and it's in dark chocolate. And so we do like resveratrol for boosting the immune system. So doing those things is important. Getting the right vitamins, and Amber has put a bunch of vitamin labels back there. We do sell our own vitamins, and the reason why that's important is that our vitamins are third-party validated, and not everyone in the industry is. In fact, I would say the minority are. And what that basically means is they've undergone rigorous testing. So that coupled with something we call GMP standards actually makes sure that whatever is on the label is what's in it. And we call that prescription grade vitamins. Really important. So, I'm not saying buy ours. I'm saying when you do buy a vitamin, it might be on Amazon or eBay cheap, but Google up that company and see if they actually have third-party validation and go by what we call GMP standards or GMP guidelines. It's really important to know what you're getting. It's interesting that vitamins and supplements do not have to be and aren't FDA approved. They're just watched by the FDA only when there's a problem and an adverse reaction associated with a vitamin or supplement. That's the only time the FDA gets involved. So that's a problem. Anyhow, so immune system is really important. Also, there's another group of drugs that we're using. I've mentioned the ARIs, the androgen receptor inhibitors and PARP inhibitors, but there's another category of drugs called immunotherapies, and they specifically boost our immune systems to thwart the cancer. And that's a whole nother talk, but I can touch upon it. Yes, sir.
Well, thank you for saying that. I take most of those things you're talking about, and I drink plenty of red wine. So thank you for saying that.
In moderation.
Yeah. My question is, I've been to several urologists. One urologist, I won't tell you his name, but as you watch this PSA test, and it goes up, and then it goes down, then it goes up, then it goes down, then it goes up and up and up, and you get MRIs, biopsies, all this, then it goes down a little bit again. I don't know. I've had physicians tell me that every man, and if you live to be 100 or 90, you're going to have some kind of prostate cancer. What we don't want, I guess, is the aggressive culture of that. But this urologist said to me, he said, I don't know why people in their 70s are going out and getting a PSA test, because it's a blood test. It's not a cancer test. And he said, you may fire me for saying this, but he said, it's just, to me, it's sort of like almost useless. I go, well, useless. That's kind of the baseline. So I'd like to know more about that test. And you've had, what is the other? There's another PSA test that's you send off to Pennsylvania or somewhere, or I can't even remember the name of it, but
Or
then they put you in a percentile of where you would be if you have prostate cancer, you know. So, you know, what's the validity of that, and is that really what is used, and or
Yeah.
how should we worry? Because when it's high, it gets up to 6, 8, 9. You know, all right, people are, that's what this doctor said. He said, all you're doing is worrying. He says, it just creates worry. Stop worrying. So that's kind of what I wanted to bring up.
So the gentleman's asking about a concept we call, or a topic we call PSA kinetics. And, you know, the fact of the matter is in contrast to what your urologist did say, is that it's just a blood test. It's the only blood test that we have that can point us in the direction of prostate cancer. There aren't many tests like that in oncology medicine. They don't exist, in fact. I mean, there are some, you know, which are close, like a CA19-9, maybe for pancreatic cancer, but it's not so good as PSA. So the job is to try to figure out how to interpret the PSA. So it appears that the number, whatever that may be, is not as important as the rate of the rise of the PSA. So for example, if a patient has a PSA of 6 or 7 or 8, that's a number, maybe important, may, you know, be worth, you know, doing an examination with a digit, you know, finger examination, or maybe tracking it again. But that's not nearly as important as the patient whose PSA was only 1, and then 6 months later went to 2, and then 6 months later went to 3. That's the PSA rise that gets our attention, because then something's going on. Because after all, normal prostate cells make PSA, okay? And the bigger your prostate gland is, the higher your PSA can be. Additionally, the prostate, as you all know, is subject to having bother throughout your life. And as we get older, the prostate bothers things more. It gets inflamed more. And if you inflame the normal prostate cells, they become inflamed, and they just spit out more PSA. So it's not uncommon to see a guy who has a PSA of, you know, 10 or 20 or 30 who has something that we call prostatitis, which is an infection of the prostate. Sometimes you can't even pick up the infection. It's just more of just an inflammation of the prostate. So it's more about the rate of the rise than anything else. Now, person has a PSA of 6 or 8, as I said, and he's got a first-degree relative or family history of prostate cancer, that makes it even that much more relevant. If he's got a family member on the female side who's had breast or ovarian cancer, that makes it even that more relevant. So there are other things that we need to know. If a person has a PSA of 6 to 8 and he has a lot of urinary symptoms, well, we may not be thinking much about cancer as we are prostate inflammation, but it's still worthy of checking. There are a host of other tests which are looked at, and I think that's what you're referring to, tests like Polaris and Decipher. And what they've all tried to do is to figure out if you do have a PSA rise, how important is it, and does it translate into cancer? And if there is cancer, how aggressive might the cancer be? But they're all flawed. Okay, they're not 100%. I would even say in my experience, they're hardly 50%. So they're part of the equation, but not a big part of the equation. I think that if a person has PSA elevation, first thing to do is, again, a good digital rectal exam, as we call it. It's a finger exam of the prostate. And unfortunately, a lot of doctors aren't doing that anymore. You know, that's a problem. But there are other tests. So if the suspicion gets a little higher because the PSA is rising, or there's no explanation for a PSA of 6 or 8, the prostate's not enlarged, having 0 urinary symptoms, well, then it is concerning. So you have to put it all into the mix and figure it out. But, you know, I would say it is still a relevant test and should be done. You know, I'm not one who thinks that we should just be dropping it because of age, because, you know, we're already here, well, you know, you'll die of something else. Why are we doing this? Everyone gets prostate cancer. That's not necessarily true. And we are seeing more aggressive prostate cancers now. We don't know why, you know, but of all the cancers that we've been looking at, there was a 2020, it was either 2020 or 2022 study, and it looked at and found that most cancers, just about every cancer, was on the decline, okay, and they're less aggressive. With a couple of exceptions, prostate was number one. It's on the incline, okay, and more aggressive cancers are being diagnosed. That's important. We don't know why, okay, but that's what we're finding. The other one, by the way, is GI cancers in younger people, you know, 20 to 45. We're seeing a lot of colorectal cancers and GI malignancies, gastrointestinal malignancies in younger people. But no, the PSA is important. It all has to do with, you know, how in the background of the rest of the story, you know. I mean, look at, you know, President Biden wasn't checking it at all, and look what happened, you know. So he has bad disease. So
it was a 4K test. That's the one I was trying to think.
yeah, the 4K score is interesting. So there's a test called 4K, and you basically subject your urine to it. Of all the ones, actually, that's shown us to be maybe the most accurate of them all. And if you're in a position where you just don't know, you know, does a person have cancer? Does he not have cancer? Should he get a biopsy or not? You know, 4K score is interesting because if it comes back strongly positive, then, you know, it points us in the direction, yeah, you probably need a biopsy. But typically, I would like to have an MRI done first before I do a 4K score, just because MRIs have gotten really good, okay? And, you know, the radiologists have gotten extremely good at interpreting them. I can remember, and it wasn't that long ago, when MRIs were done for reasons of having an elevated PSA or some suspicion, and the best that a radiologist could tell us was, well, I think there's a cancer in the prostate. And that's what they told us, and that was about 10 years ago. And since that time, what they've done is they've increased the strength of the magnet associated with MRI imaging. And I have to say most communities in this country now have stronger magnets associated with their MRIs for prostate review. And with that, we've gotten a lot more information about the prostate. And that all happened, I would say, within the last, you know, 5 to 6, 7 years. And then even more recently, there's another way of looking at the prostate, and it's called multi-parametric imaging of the prostate. And you look at a whole bunch of sequences, and it's a phased array, and you look at T1 and T2 and contrasted agents. Now, the radiologists have gotten so good, now they typically say, oh, there's a cancer. And we're predicting that cancer is going to be this aggressive. And they have a scorecard now, it's 1 to 5, and it's called PIRADS. And, you know, if any of you have had prostate cancer and you've had an MRI, you can go back and look at your report, see where your PIRADS was. Because the radiologist will now say, well, on a scale of 1 to 5, I predict it's going to be, and 5 is the worst, 1 is the best. I predict it's going to be 1 or a 2 or a 5. And they've gotten very good at that. I do a lot of biopsies here. The only thing I found a little different, and it just, again, this might still depend on how good a radiologist is. They may get the grade wrong. So they may call it a PIRADS 5. And if there is, it's almost always a cancer to biopsy, but it may not come back as a Gleason 9 or 10, you know, as a PIRADS goes. So Gleason scores also go from lower to higher, with the 10 being the worst. You know, when a pathologist looks at your slides under the microscope. And that's determined, by the way, you know, again, I do lots of biopsies, and you send these little snippets to a pathologist, and his goal is to look under the microscope and tell you, number one, how aggressive is the prostate cancer. And he also has a scorecard of 1 to 5. 5 is the most aggressive, 1 is the least aggressive. And so the first thing he says is, what is the most prevalent cancer in this little snippet? And let's just say on a scale of 1 to 5, he calls it a 3. Okay, he puts that number down. He looks again. He said, okay, on a scale of 1 to 5, what's the next most common? Because typically prostate cancers come in different varieties. And so there's often kind of a smorgasbord of grading. And then the second one he looks at is he says, okay, what's the next most aggressive cancer I see? And he may say it was a 4. And you get a 3 plus 4 equals 7. And that's how that scoring goes. Now, many people do have just a more homogeneous gland where everything is Gleason 3 plus 3. So he sees a 3 and a 3. But it could be a 4 plus 5. It could be a 4 plus 3, or, there's different ways of doing the math. So, yes, sir.
All right. Could you talk about brachytherapy and the process of so how some people get a prostatectomy, some people just get radiation, some people get radiation with brachytherapy, and is it still used, and what's the difference between those three things? And what happens to the seeds after the job's done?
So he's asking everything about brachytherapy. Okay, so I have a great interest in brachytherapy, as I was kind of one of the pioneers of it back in New York a long time ago. I was doing other things, like surgical removal of the prostate. I'm not a big fan of it, but I started doing brachytherapy, and what it implies is putting these tiny little radioisotopes. They're tiny, you can hardly see them, directly into a tumor. That's actually what brachy means in Greek. It means in close proximity to. So it's in close proximity therapy, and we're actually putting them directly into the tumor. I know of no better way of eradicating a prostate cancer than with brachytherapy. Now, you have to put many, okay? You want to address the tumors, but you also want to get a dose that could potentially sterilize other cancers that are lurking in the prostate. But it's done typically as an outpatient. It doesn't take long. There is no cutting, there are no incisions. And so it tends to be a very palatable treatment, especially compared to prostate surgery, radical prostatectomy, or Da Vinci robotic procedure, where you actually remove the prostate. But prostate brachytherapy is interesting from the standpoint of delivering a very high dose to exactly where you want to put it. And to this day, we don't know of another type of radiation that works as precisely. It works where you put it, so you better do it right, because if you don't put brachytherapy material exactly where you want, that area is not going to get treated. It's going to be untreated. And so it's that's important. There are different ways of doing brachytherapy, and I've done them all. I've done tens of thousands of procedures, and for a while I was doing something called temporary seed implants, where you actually put them in and then you take them out. I don't like that type. It is a therapy. It is brachytherapy, and there are places that do that, but it's a very penetrating isotope. And so again, kind of being from the beginning of brachytherapy, what attracted me so much was its precision. It worked exactly where we're putting it, and it didn't make it, to this day, it doesn't make sense to me that you put in a material which isn't that precise and which actually generates dose to your whole body and outwardly. In fact, when I was doing these, and it's all because of the isotope. So with temporary implants, you use a material called iridium-192, very penetrating isotope. So if you put it here, you're getting a pretty good dose, solid dose here. I used to actually have guys, when they were getting treated, it would take about 10 to 15 minutes. You'd repeat it many times, 5 times, 6 times, and I would have them stare at their groin so they wouldn't get cataracts, because they're really penetrating. So you can understand why it kind of defeats the whole purpose of brachytherapy. And if you're doing that, then I would make an argument, well, why not do external beam radiation, especially since we have all these real precise permutations of external beam radiation now. Here we do one called DART, and it's extremely precise. And I would say that makes a lot more sense to me, because you're not irradiating all the surrounding tissues to such a high dose. But prostate brachytherapy as a sole treatment, I had the largest series in the world in New York, and I was compiling the data. And as time went on, I didn't know why there was a failure rate, because if a patient's PSA was going up, I would do biopsies. At the time, I was doing something called saturation biopsies, where you do like 30, 40, 50 of the gland. They would almost never come back positive after brachytherapy, letting me know, it was a great treatment for where the prostate cancer originated. The problem with prostate, and this is really the problem with prostate gland, and if this is your prostate, and it looks something like that. It's not like a walnut or a kiwi. It's actually more like a heart, where the bigger part is the top, the smaller part is we call the apex. We call this the base. We call this the apex. Also upside down, apex being typically on the top. But that's how it's shaped, and it has a segue of a right and a left side, and the urethra goes right down the center of the pipe that joins it. But most prostate cancers don't begin here or here. They begin here. They begin here. We call that area the peripheral zone. And that's the name of it, and that's where virtually all prostate cancers begin. If they do begin in the central or transitional zone, it's usually in addition to the peripheral zone. So what happens is with prostate cancer is just like other cancers in the body, and we talked about, a cancer being unbridled growth. You can't catch up with it. It's growing faster than the normal cells. The second thing they do is they infiltrate the surrounding tissues. That's a second principle of prostate cancer. And so they commonly do this. But what makes the prostate interesting is that it does not have a capsule. And other areas in our bodies typically do. The prostate doesn't. And that makes it interesting because without a capsule, the cancer can do this also quite easily, and it does. And that's a problem because most therapies are directed to the prostate, okay? And that includes my seed implants. Brachytherapy is directed to the prostate. And so I had already come away from, the surgical realm doing radical prostatectomy, and found that there was a lot of failures associated with it. Interestingly, with prostate surgery, not only are there failures in the region of the prostate after, but there's also more higher prevalence of developing distant disease, lung, liver, bones, because it's a bloody operation and it can actually disperse cancer cells. But brachytherapy, as I was mentioning, I put the seeds, these little pellets, directly into the tumor and around it. The problem is if the prostate has no capsule, which it doesn't, other organs in our bodies do, just about everything in the urinary system does. The bladder has a thick capsule, kidneys have a thick capsule, even the testicles do. The prostate has none. And so the cancers can migrate out or leak out, you can think of it, early on. And even the seed implants, as good as they are, as I mentioned, they're very precise. So they could actually miss tumors over here. Now, I even developed a style, and I published on it, about putting seeds outside the prostate cancer. And I do that, okay? I don't know many who do, but I do. And it has to do with, because the immediate question that comes up is, well, if you're doing that, those seeds must be taken off all over the place. And they're actually not. And the reason they're not is because there are two types of seeds. And the seeds that we use here are typically palladium and cesium. And if you were to blow up a seed, 10,000 times, the seed would look something like this. And it has these very concave ends. And in contrast, every other seed in the industry doesn't have that. They're more like this, and they're kind of bullet shaped. And because of that bullet shape, if you put a seed out here, well, it could migrate, okay, out, just leave the area altogether. But with this seed that has the concave ends, and I have a tool that fits directly into this concavity, and I spin it, and what it does, it locks the seed in. So seed migration is really not a problem here because of that. And also because of that, I can put seeds directly out here. But what I can't do is put them out here. where the cancer is going to, and it's a really common phenomenon. And what they also like to do, cancers do, is they like to go to these little structures that live out here, and they're called lymph nodes. And our bodies have more lymph nodes than we have vessels, and they actually begin in our feet, and they end up draining in our neck, and that's the direction they go. It's always upwards. And lymph nodes are in our bodies to remove things that are not supposed to be there, and they will remove infection and inflammation because they're not supposed to be there. I often tell people you may have had a swollen lymph node in the neck accompanying a sore throat, because that's what lymph nodes do. And then it gets rid of it, it drains out. By the way, the only ones that go down are the ones from our neck, go down to the top of the neck, and everything else goes up. But cancer is foreign, and so the lymph nodes grab cancer up really early on. And before the advent of, and many of you may know what a PSMA PET scan is because you may have had them, we were doing nanoparticles here. It was a very interesting test, and it showed us so much. We got a schooling on lymph nodes and just how common it was for lymph nodes to be involved. And we came to find they're involved a lot. And, rarely does a patient escape without having some lymph node dispersion. Again, one of the problems with the current way of removing the prostate surgically, radical prostatectomy, is that you can't really get to those lymph nodes. So when you read about it, or those of you who've had radical prostatectomy, the lymph nodes that are typically removed are down in the femoral and inguinal area, and they're not commonly involved. Back in time, 30, 40 years ago, they used to do an incision when they did the radical removal from the belly button down, open you up. And then could be, 10 to 15 lymph nodes were sampled at that time. It was more both diagnostic and therapeutic. But these days, I rarely see more than, let's say, 4 lymph nodes. Hardly ever see it, maybe 1 or 2 removed. And there are typically ones down here that are not so commonly involved. The problem also with removing back in time all those lymph nodes is, again, the lymph nodes serve a purpose, and they're the drainage of lymph, which again is moving on up. And what they found after doing those lymph node dissections, is what it was called, is that there would be a backflow of lymph. And so legs would swell, scrotal sacs would swell, penis would swell. We call that lymphedema. Big problem, a really big problem. And to the point when radiation, and I was one of the people who started feeling the importance of lymph node treatment was really important to, because it was a game changer in terms of cure. But I was, the initial concern was, are we going to cause the same problem with lymphedema? And it turns out not. And now, lymph node treatment, is not only done here, but elsewhere. And no one's talking about, that problem, lymphedema anymore with radiation. I mean, it's possible, but it's very, very, very rare. But it was with surgery. So the bottom line being is that because of the outskirt nature of prostate cancer from the get-go, because of its location in the peripheral zone and the fact that the prostate has no capsule, while the seeds are great treatment for the inside, it's not addressing the outside. And there are some areas where the outside kind of travel off, and it's a certain space that the prostate cancers track to get to the lymph nodes. And so it was necessary then to treat the lymph nodes in addition to the prostate, okay, to really, get a really high cure rate. And when that was done, and when I started treating lymph nodes, it was a game changer from the standpoint of curing the disease. But again, the control of the local disease is really high with seed implants. But there can be failures local, regionally. I have them myself. They're not so common, but it happens. And we usually have to biopsy it. Interestingly, the current tools that we use for prostate cancer after treatment, which right now is PSMA PET scans and sometimes even MRIs, the areas where they tend to have false positives are right here. And so they often miscalculate, and they say there's tumors in the prostate, and it's typically not the case. So high rate of false positivity. But combined treatment is wonderful. Now, some patients, we just do the DART alone, and it's a very precise type of radiation. It just basically means that we have to go farther, we have to go longer, we have to treat to additional dose, because the seed implant takes care of such a high dose to the prostate, whereas if you don't have the seeds, you got to make up for that dose, and to do that, you got to use higher doses of the DART, and I don't have data on that. So right now, if you look at data with brachytherapy, it's the best. Okay, there's no question. So if you look at data, comparing surgery to seed alone, to radiation of the external variety alone, no matter what kind, protons, neutrons, photons, or electrons, or combining it, prostate brachytherapy and the radiation, the combined modality definitely results in a higher cure rate, both local control and higher cure rates. Now, as I said, I don't know, since we have DART, we can go to these really high doses with DART, and many men opt not to have brachytherapy because they just may not like needles or something, or they think it's still like an operation, which it's not. But if they don't, then the best we do is DART, and I don't have the long-term data, and as I do with the combined treatment with radiation and the seeding, which I've published extensively on 20-year data. So, all right, yes, sir.
It's hard to nerd on this stuff, but it's fascinating information. I try to study and learn as much as I can. I had a great meeting with Joni.
Oh yeah.
And to see the graphics and understand the sensitivity and attention to the lymph glands, the nodes, and to the seminal glands,
yes,
and whatnot, and also the disbursement of the DART program, the radiation, where you have the 100%
yes.
area, and my spots are right on the periphery, and how it's dispersed in smaller increments. I mean, I can't understand how or why, but I got the gist of it. And also protecting the urethra and external areas of how that's kind of, wow, too much information, but it's fascinating. And then, but it gave me a good graphic. But then with the brachy program with the seeds, my cancer is in the periphery, just like your diagram. There's a couple of spots. One was a 6, one was a 7. You were more concerned with one than the other, and whatnot. But I got the gist that the seeds are put throughout the whole. I don't understand the disbursement. Maybe 75 to 100 of them throughout the entire prostate. One, because there are things that are unseen and it's preventative. Could you elaborate on that a little bit? I mean, I'm doing the best I can.
Sure, I get it. So he's asking a question about seed placement, basically. Okay, and so while I've shown you the fact that I want to deliver a higher dose to this tumor, so when I see a tumor, and we have an advantage here because we use 3-dimensional color Doppler ultrasounds to pick up exactly areas that need to, or that warrant a higher dose with brachytherapy. But we also know that there's a phenomenon that we call field effect, and cancer field, a cancerization of the field, which basically means that whatever happened here to create a tumor is happening here, here, here. And over time, left to its own accord, will show itself. It'll become malignant. Okay, and there's 2 areas of the body that we refer to. One is the breast, which is interesting, in women, and that's fed by the female hormone estrogen, prostate by testosterone, and they both have this field cancerization. And by the way, for any of you who know about breast cancer, they also like to go to lymph nodes. 2 areas of the body that really like to go to lymph nodes: prostate in men and women having breast cancer. But because of this field cancerization phenomenon, we know that if we just treated this, then you're and as I told you, seeds are really precise. Okay, then you're actually not treating some tumors, which may be bad apples, not now, but in the future, or they could be there from the get-go, and they need to be addressed. So there's actually 2 styles in the United States, And I started the style on the East Coast, and there's a style in Seattle. In Seattle, they decided that they were going to put their seeds in for the reasons that I told you throughout the gland, and they're going to do it uniformly. And it would look something like this. And so every seed is equidistant from the other seed. And that's called a uniform seed load. And yes, it will address the entire gland, and it will also address, the tumors here. When I looked at this, the problem that I had with this was if you really analyze dosimetry, which is physics, what you find is that by doing that, you're going to get a very high dose centrally. Okay, think of these as electric heaters. And if each one is an electric heater in your room, and you got them surrounded, okay, the middle of your room is going to get toasted. They're really hot, okay? Meanwhile, if you think about a point over here where there might be a tumor right on the edge, it's going to get probably a much lesser dose than a point here. And in fact, when I did an analysis of this, it appeared that the central doses were 16 times as high as the peripheral doses. It didn't make sense to me, okay? And that's the reason why I began doing what's called peripheral seed loads. And what that basically means is that you take out the central dosing. And if again, and now you put them in the periphery. And if any of you were to ever see your seed implants, you would see my seed implants. Here's your prostate, but they tend to be right around the outside. Well, the reason why you do that, again, just think about it. If these are all electric heaters, and you're sitting in the middle, you're still going to get pretty warm because you have a contribution from all of them, each and every one, going to the center. It'll get a sufficient dose to eradicate microscopic disease, but it won't blow up the central dose where you get really hot, which is a problem because that's where your urethra lives. And your urethra gets really hot with the uniform loads, and that's a problem. So putting them in peripherally is what makes sense to me, and I published on it. And then in addition to a peripheral load, if there's tumors, those tumors I make sure get an extra dose just inside and outside.
And on that, just curiosity, I had my biopsy last month, and in effect, this is a transperineal format for the brachy with the needle loaded with the seeds. So if there's 75 seeds, I mean, is the needle reloaded, or how does the mechanics work on
Yeah.
That's a fair question to ask.
Yeah, so the gentleman's wanting to know, you have 75 seeds, so I put in 75 needles. Absolutely not. Okay.
I didn't think so, but I was curious.
So each needle carries 20 seeds. Okay, and so what I commonly do is I look at the prostate and I see there's a row going like this. And so what I'll do is through the perineum, I'll come in and I'll have a needle go like this around the bend, and then pull it back and drop the seeds exactly where I want to. Okay, and by doing that, you basically minimize the amount of needles, and trauma that the area gets.
Thank you.
Sure.
My son's an EP cardiologist, and this sort of sounds like he does an ablation. I mean, you better get it right, or they're going to have to come in for another one. So this seems sort of similar in a different way. My question really is, these are radioactive seeds. Do they stay there? Do they die out? I mean, I know there's a half-life and everything, but how long are they stay in there forever, or what's the deal with it?
Yeah, so he's asking about the staying of the seeds. So yeah, they're permanent. Okay, but they're made of material. Again, they're tiny. They're made of material which is tissue equivalent. They're completely okay with your body's stroma. So they're not rejected by your tissues. They're accepted because they're made of material that is accepted by tissues, and they don't interfere with anything. So if you ever needed an MRI or a CAT scan, or if you need a pacemaker or defibrillator, no interference at all with the seed. So they're put in there and they stay. And, we use special methods to show them, to highlight them. You know, I mean, because not every test is going to show a seed, but we do because we know patients got seeds, and we do localization of your prostate brachytherapy. But the gentleman also brings up something called ablative therapy, and I used to do that in the Northeast, and you may read about it. There's different types. One is called cryosurgery, which is freezing the prostate. The other is called HIFU, which is heating the prostate. And the reason why I got away from doing that is, and with those treatments, what you do is you say, okay, there's a tumor here, and I'm going to focally ablate it either with heating or freezing by putting a needle in, and then go right inside the tumor, and then I'm gonna freeze. It's a freeze ball. Now you can't go outside because there's just too much critical normal tissues outside the prostate, and you don't want to be damaging because ablative therapies, they do damage, they eradicate the tissue. Okay, but the problem that I found when doing those kinds of therapies was, okay, this is the tumor, you ablated it, and at first it looks good because your PSA, let's just say it was 5, it goes to 2 or 3, but not for long. And that's what the data shows, and it starts increasing again. And it increases again for the reason I told you, and that is that other areas of the prostate become cancerous. For whatever reason, you know, it wasn't because, you know, they're all subject to, in your particular case, having bounding testosterones when you're adolescents. Was it because you have a family member or family history of prostate cancer? You know, was it something you came in contact with in your lifetime? You know, some solvent or something that caused the cancer. But whatever it is, we know is affected the whole gland. And if you just treat an area, well, sooner than later, you're going to be dealing with another tumor in the gland. And the whole objective of doing those focal ablative therapies, if you read about it and, you know, the literature, it'll talk about, well, you know, you can avoid surgery, you could even avoid radiation, and you could just get that done, and, you know, we'll do it once and be done with it. But it's rarely once. And if you do it once, you might not have that many side effects. But if you do it twice, and typically 3 or 4 times or 5 times, then you've gotten them all. I came to find that after I did the second one, when I was doing this, patients were having an awful lot of side effects. And it is because of what I told you. It's very ablative, so it damages, it eradicates the tissue, and it becomes a big scar ball. So anyhow, that's, and there's one other, it's called the, it's where you load centrally, and then, I'm trying to think of, I can't think of the name. Tulsa procedure. It's a Tulsa procedure. You actually put a probe directly in the urethra, and then you shoot out your heat waves. Anyhow. Yes, sir.
I'm curious how you correlate the various tests, like the 4K score with the Gleason scale. And, how do you put it all together?
So the gentleman's asking about 4K score, and, you know, we do use it here. It's you know, one of the few predictive tests we use, and the reason why I do use it here, because it does appear to be predictive. A lot of the other ones, the Prolaris, the Decipher, the ExoDX, I just abandoned them because so many times they would show me a low probability, low aggression, you know, low probability of it spreading and even having cancer in the first place. And then I would do the biopsies. They'd come back as like a Gleason, 10, and it would be spread to different areas. So I don't know, I just had kind of a bad experience with it. But the 4K score has guided us a little better. And typically, I mentioned the MRI, and the MRI is pretty good at showing us, the probability of there being a cancer and maybe even the prediction of how aggressive a cancer is, but not always. And it could be right in the middle. Like I mentioned, there's a 1 to 5 score. What do you do if it's a 2 or 3? Okay, and what do you do if your prostate's really large too? Because then we also know the MRI's predictive ability is a little less, okay, because it has to look through all that tissue, okay, and it just doesn't do as good a job. So that's where I use a 4K score to identify if that person should undergo a biopsy after having an MRI, okay, and that's how we do it here. Also, we have other instruments beyond the MRI. It's called a three-dimensional color flow power Doppler ultrasound. And, it's fairly unique. Now we used to have one in here. We actually have 3 of them, and they're not common technologies. There's few in the country. There's one in Arizona, there's one at UCLA, there's one in New York City, there's one in Munich, Germany. We all know who we are. But they're really interesting instruments from ability to tell us about cancers and their location, maybe even a little better than an MRI. So that's another test I like to do in addition to the MRIs and the 4K scores to try to figure out a tumor, its location, because, sometimes there are tumors which, they've made inroads, they've grown, and they made inroads out of the prostate. And it's not so uncommon, again, because of the fact that the prostate has no capsule and the cancers begin right on the edge in the so-called peripheral zone. And, we worry about those. It doesn't have to be an aggressive cancer, but it could be a high volume cancer. And if that's the case, we worry about it because it has access. And I've already mentioned the 2 principles of cancer: unbridled growth. Second is infiltrating surrounding tissues. But the third one is that they love to gain access to your vascular network and spread distantly. So those are the reasons why, that's what defines a cancer, those 3 principles. But for that reason, if there's a higher volume of cancer, it's important because it can gain access. Also, because cancers always become something worse. They don't become better. They don't. And sometimes, for example, I have patients who I do something called active surveillance, which means I don't treat. Okay, I just follow them. Now, I have my own selection criteria for doing that. But I pay close attention because, again, cancers always mutate to become something more aggressive. So, for example, a 7 doesn't become a 6, an 8 doesn't become a 7, a 6 doesn't become a 5. They always go the other way, they become more aggressive. And when they do, they actually make less PSA. And the reason they do that is because, again, prostate cells make their own PSA. And so if the prostate cell becomes malignant, then it's going to throw off more PSA because it's unbridled growth, it's growing faster. But as it mutates, it starts looking less like the prostate cell altogether, and it's not obliged to make any PSA. And so as we go up in the spectrum of Gleason scores or aggressiveness of prostate cancer, the PSAs actually start going down. So it gets my attention often in a patient who I'm just following, is if the PSA was kind of perking along, going up a little, but if it starts going down, that gets my attention, just because it might mean the cancer is really mutating and it's concern. So, are there any other questions? Yes, sir.
You already answered most of my questions.
Yeah.
But so what state does it leave the prostate in? Does it vary, meaning different therapies, like if you have seeds? It's still, it's a functional, it has a function. It eliminates the function.
So he's asking the treatment result of any kind of treatment, I suppose. So, prostate is first and foremost a sexual organ. It's the G-spot in men. It has a lot to do with the creation of the ejaculate, which it stores above it in these reservoirs we call seminal vesicles. And, what happens is, so it does that. It carries the nerves that go to the penis, and it has a lot to do with the orgasm. So, having said what I just said, if you think about it, if you have it surgically removed, well, you can almost figure that out. You're going to have a big, bad problem. Even those guys who can get an erection because they get a penile implant may not be able to get an orgasm. But I would say that by and large, that's surgery. So with surgery, everything is down. But with other treatments, the prostate's still standing, okay? And it's tenacious, it'll get out. It could put up with quite a bit, normal tissues can. Normal cells put up with a lot, okay? Connective tissue, muscle tissues, they're really strong. They take enormous doses of radiation to actually eradicate them, a lot higher doses than cancers take. Cancers fold earlier on. So you still leave the stroma, but I think many men will find after undergoing radiation or brachytherapy and radiation, they're going to have diminished ejaculates. So it's typically diminished in volume and changed in consistency. It might be dry altogether, but sometimes, as men get older and their prostates get bigger or just get older, the ejaculate dries up anyway. Okay, so we kind of never quite know with follow-ups. We do go out of our way to avoid a big grouping of bundles astride the prostate, which are called neurovascular bundles that are carrying the nerves that go to the penis. And so that typically is preserved. And then, of course, the orgasm is typically preserved. But sometimes you never know. I mean, you can go out of your way to be as careful as you can with all the things that can cause erectile dysfunction, and you still get it because the prostate is first and foremost a sexual organ, and it's finicky. Sometimes you do anything to it. Just like men who have enlarged prostates, they can find that their erectile function is going down, and it's just because the prostate is a sexual organ, it's getting larger, and all the normal functions, including making an ejaculate, diminish. So, all right, I think that concludes our session. Thank you all for coming.
Thank you, Dr.
Yeah, you're welcome.